Hey, good afternoon, everyone. We're going to get started. Really excited to introduce Dr. Steffi Sathiyaraj. She's our senior and co-chief nephrology fellow in our division. Dr. Sathiyaraj did her medical school at Sri Ramachandra Medical College, and then subsequently did residency at University of Rio Grande Valley in Edinburgh, Texas, and obviously is finishing up her fellowship here with us. During her fellowship, she's done a lot of work with education and received a physician educator certificate and functioned exceptionally well as our co-chief fellow. I'm really proud of her achievements, and I'm also excited about the topic that she'll be presenting today. Welcome, Dr. Sathiyaraj, and please go ahead.
Thank you, Dr. So today my topic is cardiovascular kidney metabolic syndrome. And hopefully by the end of this talk, we could all close the gaps between obesity, heart, and kidney disease. So first, I'll go over a brief overview of this presentation. First, we will take a look about the importance of the presidential advisory from the American Heart Association. Next, we'll provide more clarity on the definition of cardiovascular kidney metabolic syndrome, which we can also refer to here on as CKM syndrome. Then we'll talk about an approach to CKM staging that promotes prevention and that can help reduce the likelihood of progression and discuss optimal strategies for the prevention and management pertinent to each of the CKM stages. Then we will discuss social determinants of health and their impact on CKM health. And lastly, we will go over risk prediction algorithms that include exposures and outcomes most relevant to CKM health before we wrap up and conclude. So in November of 2023, the AHA released a presidential advisory discussing the importance of CKM health. And I think the first thing to understand is why this is so important. The reason it's considered such a public health emergency is that there's such a high prevalence of poor cardiovascular kidney metabolic health in the population, which affects nearly all organ systems and has particularly powerful impact on the incidence of cardiovascular disease. So a lot of what I'm going to say is also echoed through a great presentation, which was found online by Dr. Chiari, who is a cardiologist and one of the main contributors to writing this presidential advisory. So as we can all appreciate this, we know the leading cause in our CKD population, especially the ESRD population, is cardiovascular mortality. So this graph shows an unadjusted relative percentages for death by cause and eGFR. It shows the relative percentages for death by eGFR by category divided into CVD, neoplasm, infection, and other. The most common cause of death for those with eGFR greater than 60 and no proteinuria was cancer. However, you can see the most common cause of death for those with eGFR less than 60 was cardiovascular disease. And again, we see that echoed here in this image, and this image shows the association of CKD staging by eGFR rate and albumin to creatinine ratios categories and their risk of complications. As you can see, regardless of the age, on the left you see age less than 65, and on the right you see greater than 65. As you have declining GFR and progressively worsening microalbuminuria, there is significant events that occur. So from kidney perspective, you can see the progression to kidney failure, AKI events, and hospitalizations increase as there is a decline in our kidney function. But however, as you can see, there's also from CVD perspective, you can appreciate there's increased CVD mortality, MIs, heart failure, AFib, and PAD that's also increased. As you can see from the various studies that I've outlined here, there's definitely been an association between cardiometabolic disease. And we also know the widespread appreciation between the heart and kidneys known as cardiorenal syndrome. But now there is a growing awareness that metabolic abnormalities also play a key role in the cardiovascular kidney interactions. So again, going back to the importance of this advisory released by the HA, it provides a framework to improving CKM health in our population. So instead of considering cardiorenal syndrome and cardiometabolic disease as separate entities, it's become increasingly clear that we need to consider their overlap as CKM syndrome. And also it's important because of the clinical consequence, which is premature mortality in the CKM population, which is due to an excess burden of cardiovascular disease. So in this graph, we can see it depicts life expectancy of men at different levels of kidney function indexed by age. The x-axis is age and the y-axis is life expectancy in years. The bars represent different stages grouped by eGFR. The solid bar representing GFR greater than 60 and the striped bar representing GFR 15 to 29. As you can see, compared with middle-aged individuals who have normal or mildly decreased kidney function, those with stage 4 or GFRs in the 15 to 29 range have greater than 20-year shorter life expectancy. And this is also seen in women as well, with lower GFR associated with a shorter life expectancy. In this graph, it describes total life years lost to people with type 2 diabetes by age at diagnosis. Additionally, we can also see that men and women with diabetes have 13 to 14 years shorter lifespan than their counterparts without diabetes. And in this graph, it describes all-cause mortality versus BMI for each sex. And as you see, with progressively more obesity, it is linked to a reduction in median survival as well. So in the last few slides, I've described that CKD, diabetes, obesity all confer a mortality risk. But it's important to know when compounded all together, there is a synergistic effect in mortality as well. And this graph highlights that. As you can see, in patients with diabetes and CKD, synergistically, it led to higher 10-year mortality rates. So next we will discuss the definition. And it's important because this is a problem that touches base on most specialties. It's not just dealing with nephrology, but also deals with endocrinology, cardiology, dietitians, but also our primary care physicians. So a major theme that we will see in the rest of the talk as well is understanding CKM health is to reduce the fragmentation of care and providing care to our patients in a more holistic approach. And again, it comprises of three main components, which is this interaction between metabolic risk factors, CKD, and cardiovascular system, leading to multi-organ dysfunction and a high rate of adverse cardiovascular outcomes. The presidential advisory also provided a more simplified and patient-facing definition, which is on the right, which says it's a connection between heart disease, kidney disease, diabetes, and obesity, leading to poor health outcomes. So overviewing the stages of CKM syndrome, currently evidence indicates that CKM syndrome is a progressive condition that commonly begins in early life with biological, social, and environmental exposures or pressures. So in recognition of this concept, the advisory proposes classifying CKM into 5 stages. And this CKM model emphasizes the progressive pathophysiology of CKM syndrome. As we can see in stage 0, there is no CKM risk factors. Stage 1 is where we first see the accumulation of excess and dysfunctional adipose tissue. Stage 2 is where we see that over time, the progressive adiposity with resultant inflammation, oxidative stress, and insulin resistance leads to the development of these metabolic risk factors in CKD. And finally, stage 3 and 4, we can see the stepwise increase in the absolute CVD risk, where there's subclinical and then clinical CVD respectively. And in the following slides, we will go in detail into each stage and highlight key preventive strategies and interventions as well. So again, stage 0 is defined as the absence of risk factors. And the risk factors we're looking at is BMI, waist circumference, their blood glucose levels, lipid panel, and there's no evidence of CKD or CVD. As you can see, everything is normal. And here's a great visual of the stages of CKM that the advisory released, and we'll break it into parts. So again, stage 0, no risk factors. And the focus of stage 0 is primordial prevention, which with a goal of keeping them in stage 0 and preventing the development of those CKM risk factors that I mentioned, and maintaining an ideal cardiovascular health. And we do that by focusing on life's essential 8, which I enlarged here, but essentially it's focusing on a healthy diet, participation in physical activity, avoidance of nicotine, healthy sleep habits, maintaining healthy weight, lipid profile, blood glucose, and blood pressure. And we know that even in those healthy adults, some degree of screening and assessment leads to more equitable identification of some of these risk factors at an earlier stage. And then we have our next stage, which is stage 1. And in this stage, we're now focusing on excess body fat and or unhealthy distribution of body fat, as well as individuals who have impaired glucose tolerance. So that includes BMI greater than 25 and greater than 23 in Asian ancestry, waist circumference greater than 88 in women or 102 centimeters in men, fasting blood glucose greater than 100 to 124, and A1C between 5.7 and 6.4. So the underlying pathophysiology being that this excess visceral adipose tissue is associated with development of insulin resistance, systemic inflammation, oxidative stress, and those all in turn contribute to the metabolic risk factors in CKD. So enhancing recognition and management of excess and dysfunctional adipose tissue is critical for the prevention, as we'll see, of these risk factors or CKD. And we know that addressing this unhealthy adiposity is central. However, it's important to note it often does go unaddressed. One of the reasons it goes unaddressed is because there is multi-level social determinants that impact our behaviors and that impact our likelihood of developing obesity, which we'll go into detail further. Another reason this is challenging as well is sometimes we see obesity often as an individual challenge or a failure in our patients. And that brings us to the stigma around weight. And there's so much judgment, including self-judgment amongst the patients. So it's important to keep an open environment in a non-judgmental way, so they're more likely to achieve successful weight loss efforts. So understanding those complexities and challenges can lead to a more effective way of engaging with our patient. So here we focus really on healthy lifestyle changes. We also really want to have that goal of at least 5% weight loss, and that's because that's where we see some improvement in glucose intolerance, as well as reducing the likelihood of developing some of these metabolic risk factors. Pharmacotherapy in patients with BMI greater than 30, or even bariatric surgery in patients with BMI greater than 40 should be sought and looked into. And in this stage, we do advise screening every 2 to 3 years to assess blood pressure, lipid panel, and blood sugar. And again, the key in this stage is awareness and appropriate engagement to prevent further progression. Stage 2 of CKM syndrome is when there is that progression and patients now have metabolic risk factors or kidney disease. And this is where most of our nephrology population comes or sees us at this time. So this would include patients with established hypertension, type 2 diabetes, metabolic syndrome, dyslipidemia, or CKD. And I enlarged this because, again, it's important to note there's considerable pathophysiological interrelationships among stage 2 CKM components with, as you can see, metabolic syndrome predisposing to diabetes and hypertension leading to CKD, and CKD leading to hypertension. So it's important to know here also that there can be clustering of multiple risk factors in stage 2. However, most patients are completely unaware, and they're unaware that this cumulative risk is adding up and adding to their cardiovascular disease burden. And we all are very familiar with this well-established risk heat map that was created by KDIGO. We are able to stratify patients by their estimated eGFR and urine albumin to creatinine ratio. And the risk grid is important for 2 reasons. It shows the progression of kidney failure, but also shows the risk of cardiovascular adverse events. So these go hand in hand, as we described before. And so these are patients with established CKM risk factors, and the primary focus is preventing the subclinical and clinical CVD. So for hypertriglyceridemia, increases ACVD risk, and it's frequently related to metabolic syndrome and insulin resistance. So after secondary causes are ruled out, lifestyle modification is first-line therapy. And statin therapy is advised for any residual with intermediate or higher estimated SCVD risk. And for individuals with triglycerides greater than 500, we are also suggesting fibrate therapy is advised in addition to statin therapy. For hypertension management, we should follow established guidelines with lifestyle modification, adoption of balanced low sodium diet, and use of pharmacotherapy as needed. A blood pressure of less than 130/80 is the goal, and those with and without diabetes, use of RAS inhibition should be part of the anti-hypertension regimen for patients with diabetes with albuminuria and patients with CKD for additional protection of kidney function. For CKD, we really focus on patients have albuminuria, and they should, again, be on ACE inhibitor or ARB. They also highlight the use of SGLT2 inhibitors, and it should be extended to all patients, regardless of diabetes status, to protect kidney function and to reduce rates of heart failure, hospitalization, and cardiovascular mortality. And lastly, another agent that they do describe that's garnered a lot of attention is finerenone. It can be considered as added therapy, as it's shown to reduce adverse cardiovascular and kidney events, given the data from the Fidelio DKD trial, as well as the cardiovascular outcomes in patients enrolled with diabetes from the Figaro and the pooled analysis from the Fidelity trial. It shows that there is benefit on top of RAS inhibition. And lastly, for management of CVD prevention in the presence of type 2 diabetes, I like to focus on use of SGLT inhibitors or GLP-1 receptor agonists, which is advised to reduce the CVD risk. And SGLT2 inhibitors can be prioritized for those with CKD, given their protective impact, not only for to prevent kidney decline, but for reducing heart failure hospitalizations and major cardiovascular events. GLP-1 receptor agonists can be prioritized for those with grade 2 or higher obesity, BMIs greater than 35, or insulin or A1C greater than 9, or high insulin requirements. They also note that metformin use with SGLT2 inhibitors or GLP-1 receptor agonists is advised for those with A1C greater than 7.5 to help achieve glycemic targets with minimal side effects. And briefly, I just want to review the mechanism of actions of those major pharmacological agents I just described and their renoprotective and cardioprotective benefits. As we all know, ACE inhibitors are effective in slowing renal disease by diabetes or hypertension because they reduce the vasoconstriction in the efferent renal artery. And this reduces, in turn, the glomerular hypertension. And this way, less protein crosses the glomerular filter into the tubule as well. Similarly, MRAs or mineralocorticoid receptor antagonists confers the same benefits. and contributes this by improving the vascular tone regulation. And overall, there's improved renal hemodynamics and decreased renal vascular resistance. This is the mechanism of action of SGLT2 inhibitors, and it's expressed, it inhibits the sodium glucose cotransporter 2 to reduce glucose reabsorption, resulting in increased urinary glucose excretion and lower plasma glucose. And the SGLT2s are located in the proximal tubule of the nephron. And SGLT2 inhibitors normalize the decreased distal sodium delivery to the macula densa in the diabetic kidney by inhibiting the sodium reabsorption at the proximal tubule. And this in turn consequently induces vasoconstriction of the afferent arteriole. And as a result, the intraglomerular pressure is reduced and hyperfiltration is improved. And there's also benefits by promoting osmotic diuresis, natriuresis in patients with and without diabetes, and thus may reduce preload and help in our heart failure patients. And SGLT2 also may have vascular effects that promote vasodilation and reduce afterload as well. GLP-1 is an incretin hormone made in the distal ileum. It's postprandially secreted and has beneficial downstream effects as well. Notable downstream effects include increased insulin secretion with the beta cell proliferation, lipolysis, glucose uptake, natriuresis as well, and early satiety. GLP-1 receptor agonists have primarily been used for glycemic management with the goal of improving postprandial insulin secretion to minimize hyperglycemia. And by minimizing that, that's where it exerts their heart and kidney protection. More dedicated kidney outcome trials are in the works and will help us define the mechanism of action of GLP-1 beyond their effect of glycemia. And like I said, the development of the SGLT2 inhibitors and GLP-1 receptor agonists have really been a game changer, especially in the CKM domain. There has been many trials. The first three columns describe trials predominantly in patients with normal kidney function or mild CKD. However, as you can see on the right, like Credence, Vertis, and DAPA-CKD, these trials were designed to specifically explore the safety and efficacy in patients with type 2 diabetes and overt nephropathy. So as we can see in these trials, compared to placebo, it resulted in a reduction of 30% in the primary composite outcome, which was doubling of the serum creatinine, end-stage kidney disease, or death from renal or cardiovascular cause. And subsequently, the DAPA-CKD trial was designed to investigate whether this cardiorenal benefit was afforded to patients across multiple CKD stages with or without type 2 diabetes. And once again, the DAPA-CKD trial was also stopped early for reasons for meeting of the efficacy endpoints. And DAPA versus placebo resulted in risk reduction in the primary outcome, which was defined as the sustained greater than 50% decline in eGFR, end-stage kidney disease, or death from renal and cardiovascular disease. As we saw on the previous slide, there is a large body of evidence that SGLT2 inhibitors offer very cardioprotective, renal protective effects, and we're now starting to see some of the results in regarding GLP-1 receptor agonists as well, as trials have been coming out of the pipeline now. One example is the FLOW trial, which is a long-term kidney outcome trial studying the effects of GLP-1 receptor agonists, specifically semaglutide, on kidney outcomes. And the trial compared semaglutide versus placebo, and the primary outcome was defined time to any of the following events, which was GFR decline greater than 50% from the trial start, reaching end-stage renal disease, death from kidney disease, or death from CV disease. And the study actually met certain pre-specified criteria and was stopped early because the efficacy endpoints were met. And the results should be released soon and will perhaps navigate and help further give guidance to when we can start these medications. Stage 3, moving on to the next stage, is defined as subclinical CVD among individuals. And subclinical CVD principally is diagnosed either by coronary artery calcification, by CT angio, or coronary cath. And also, it's important to note they also stage subclinical heart failure. And those are diagnosed by elevated cardiac biomarkers, which is BNP, troponin, or by echocardiographic parameters. And given the absolute or high absolute CVD risk, stage 3 CKM also includes individuals with high predicted CVD risk based on the risk algorithm, or very high risk CKD per the KDIGO heat map. Stage 3 CKM is very important because it's considered a high-risk phenotype, which preventive therapies can delay or halt the progression to clinical disease and will confer the greatest clinical benefit, given the higher baseline risk than the other CKM stages. So a higher burden of subclinical atherosclerosis should prompt, again, initiation of statin therapy, especially high-intensity statin therapy. Beyond statin therapy, you may go into identify patients that would be candidates for additional therapies to support the ASCVD risk reduction, including GLP-1s, isocapen, or PCSK9 inhibitors. Subclinical heart failure, in addition to treatment of cardiovascular risk factors, patients should be treated with ACE inhibitors or ARBs and beta blockers to decrease the progression to symptomatic heart failure. And use of an SGLT2 inhibitor, again, in patients with type 2 diabetes reduces the risk and likelihood of incident heart failure, hospitalizations, and cardiovascular mortality. And lastly, the management of risk equivalence in stage 3 should also be prioritized and intensified. The previous mentioned preventive therapies if no contraindications are present. And lastly, we have stage 4 CKM syndrome, which is defined as clinical CVD among individuals with excess dysfunctional adiposity or other metabolic risk factors, or CKD. It does not just include coronary artery disease, but also peripheral artery disease, stroke, heart failure, and as well atrial fibrillation. Additionally, stage 4 CKM can be divided into those individuals with kidney failure, which is 4A, and those without, which is 4B. And the goal of management in stage 4 CKM is, again, to optimize care and secondary prevention for patients with CVD and concurrent metabolic risk factors. And as you can see, management is very similar to those of the previous stages, but I'll briefly touch on a few important points relevant to each category. The first being intentional weight loss should be a therapeutic goal among individuals with obesity and prevalent CVD. Moderate intentional weight loss of 5 to 10% should be targeted to improve metabolic risk factor control among patients with CVD, and marked intentional weight loss greater than 10% should really be targeted to potentially improve the cardiovascular outcomes in individuals with prevalent CVD. Again, hypertriglyceridemia is similar amongst the previous group, where we should really push for intensification and further lifestyle management. In hypertension, the goal blood pressure is the same. We're trying to achieve blood pressure less than 130/80. However, there is some special pharmacological considerations, including ACE inhibitors, ARBs, steroidal mineralocorticoid receptor antagonists for those with resistant hypertension. And for African American individuals, heart failure reduced CF, really prioritizing hydralazine and isosorbide should also be initiated after, of course, the GDMT is optimized. And for the management of CKD in stage 4, it does prove to be a challenge because historically there is a barrier, and we often underutilize GDMT optimization in patients with CKD. And We know paradoxically patients with stage 4 and stage 5 CKD have the highest rate of cardiovascular outcomes. So important things to note, SGLT2 inhibitors are recommended for all patients with CKD and heart failure, regardless of EF, diabetes status, and baseline UACR. And these agents can be initiated up to an eGFR in 20 and maintained until point of kidney replacement therapies. Also to note is that an angiotensin receptor ARNIs are preferred over ACE inhibitors and ARBs. And use of components of GDMT, such as the ARNIs, ACE inhibitors, ARBs, MRAs, may be limited to the presence of CKD due to concern of worsening renal function and hyperkalemia. And in order to combat that, we should really push for the use of potassium binders and simultaneously use agents such as SGLT2 inhibitors to assist in optimizing GDMT. And lastly, it's important to note that fluctuations in serum creatinine and with the decongestant therapies and GDMT use are driven largely by the expected and intended changes in the glomerular hemodynamics, and it should not prompt immediate discontinuation of these medications. We've talked about all the stages of CKM syndrome, but in order to really personalize the approach to care, we also have to recognize that there's additional factors that affect individuals' likelihood to progression of CKM staging. And one of them being social determinants of health. And that includes economic factors, social factors, environmental factors, and psychosocial factors. And we should be actively screening for those in addition to those other biological factors I mentioned in the previous slides. And here are some screening tools, and recent work has really highlighted the importance of understanding specific social needs related to social determinants of health. On the left, here on this picture, it shows numerous screening tools exist. For example, the health leads, and it helps survey financial strain, which includes food and housing insecurity, transportation and utility needs, healthcare access, education, literacy, personal safety, and need for assistance in addressing social needs. Interventions based on social determinants of health screening have resulted in temporal reduction in social needs. For example, obtaining resources for social needs related to food, housing, medication, and transportation after screening was associated with reduction in blood pressure and LDL cholesterol. Other interventions have shown that higher smoking cessation rates or greater fruit and vegetable consumption for those who gained resources, in those people who gain resources to address those social needs as well. So it's important that in the future we work together to identify these social needs and provide interventions to improve CKM health that are especially at play in these resource limited settings. This brings us to our last topic, where we discuss past and novel risk prediction models. And this was a framework of the previous ACVD risk calculator. And I want to focus that it uses traditional risk factors like age, sex, cholesterol, blood pressure, and had yes or no answers to smoking, cholesterol, medication use, or blood pressure medication use in diabetes. Notable to note, it did not give the user an option to enter anything related to the patient's kidney function. And again, some of the limitations of this existing model was that the risk estimator prevented the risk in a specific target of people which were age of 40 to 75, and it only predicted the chance of MI or CVA stroke in the next 10 years in that population, again, from 40 to 75. And so this brings us to the novel risk model that was created, which is PREVENT, which stands for Predicting Risk of CVD Events. And this PREVENT equation was developed by the American Heart Association CKM Advisory Group in 2023, and it was released just a few months after they issued this presidential advisory. And one of the focus I want to highlight is the new calculator can assess people from ages 30 to 79 and it could also predict heart attack, stroke, but also in addition, heart failure over the next 10 to 30 years. As we saw in the last calculator, it was only 10. And so it's, again, the previous calculator was designed for people starting at 40 and looked only 10 years ahead. And this one has a broader range and a broader risk estimation as well. And the new calculator, which is the most important part, I think, is it incorporates measures of blood sugar and kidney function. So the calculator includes eGFR, but more importantly, allows for the use of urine albumin to creatinine ratio to further individualize risk assessment and help inform personal treatment options. So another new feature in this prevent calculator is that it eliminates race as a predictor. And instead of race, the new model includes social determinants of health, known as the social deprivation index, which is based on a person's zip code. And this index incorporates measures of income, education, employment, housing, household characteristics, transportation, and these all show that they influence our health. And lastly, like I said, not only predicts risk for ASCVD or CVD, but also the risk of heart failure over the next 10 to 30 years. So in conclusion, how can we put all this information to use? I think the main takeaway here is optimizing CKM health in our population requires multifaceted, concerted, patient-centered efforts that require a very holistic approach. And that includes considerations of those social determinants of health that I mentioned, but also it makes sure that the patients have access to pharmacotherapies, bridging that fragmentation of care in our care teams, and just providing more efforts in CKM health and enhancing obesity management. And as stated before, I think it's really a holistic approach. So hopefully, I think this talk helps us think of CKM health in a new way and really pushes us for earlier identification and prevention as part of a holistic approach. Thank you.
Thank you, Dr. Sathiyaraj. Excellent talk. And I guess while we wait for questions, I do have like a comment and a question. One is, I think it's important for us as nephrologists. We always think about cardiorenal syndrome, but the CKM syndrome is something we really need to be more cognizant of, especially since they're incorporating albumin creatinine ratio and even social determinants of health in these risk predictors. So something we need to really pay close attention to, especially our patients with CKD and end-stage kidney disease. They succumb to cardiac disease, so we have to be pretty aware of it. And I guess the question I have is, the GLP-1 agonists, the trial was stopped early, but how soon, do you think we as nephrologists might be prescribing these agents? Or, do we defer to the endocrinologist or the PCP, or should we as nephrologists take ownership in certain cases? What are your thoughts? I mean, there's no clear-cut answer yet, but just any thoughts you have.
I think certainly I have seen as nephrologists prescribing the medication. So I think it is something we definitely can take ownership of. There is like some caveats which may benefit getting endocrine and ophthalmology on board, as well as we know some of the risk of those medications. But I think definitely starting that medication, giving that patient the education, and the risk is something that we can certainly do, and help them getting linked into endocrine is something as well.
Excellent. I think Dr. Avenatti, our preventative cardiologist here at Methodist, has a question and a comment. I'll just voice it for her. She put it in the chat. So she says, awesome overview, a couple of questions and a comment. Given workload and scheduling, at what point in the CKM spectrum would you like patients sent in nephrology for evaluation?
I think there is looking at that risk map. Let me see if I can pull it up. There. Sorry. usually stage 3B is where we kind of treat and refer. And so definitely at that stage, I would definitely think that they should be sent to nephrology or any patient where we have persistent albuminuria despite maybe the primary care initiating those initial antiproteinuric therapies as well.
And I think too, especially if they have a lot of proteinuria, that would more so prompt even at earlier stages. And then the second question from Dr. Avenatti on ACE or ARB impact on GFR. What do we do when the creatinine increases more than expected? And I think this is something we come across pretty often, and not just for ACE, ARB, but even like the finerinones and the SGLT2 sometimes. So any thoughts on that?
I know when we start these medications, we do expect the GFR to dip a little, and just making sure we monitor their kidney function closely after initiation of those medications. Also, there is like predefined cutoffs to make sure like the creatinine doesn't double more than 50%. But I think just keeping a close eye on those patients, and maybe another alternative is reducing the medication is something that has proved beneficial if we do see that rapid rise in creatinine after starting those medications.
Yeah, and to add to that, I think too, it's a matter of, do we add all, or do we sequentially add them shortly and monitor closely? But if the jump is significant, we might back off. So those are other things to consider.
Yeah, I definitely think it's a stepwise approach that we're slowly introducing these medications and monitoring their labs and trying to optimize them as much as we can.
Thank you so much. I don't know if you can.
Any other thoughts, questions, comments, feel free to voice or send in the chat.
I will just, for my comment, thanks again for the overview. Now we're all very excited here in the cardiac prevention side of things about the PREVENT. And so we'll be trying to have that implemented in EPIC. We would really like to have the score be pulled up based on the patient's information that's already in the EMR. We currently have that for the PCE, so for the pool cohort equation. So the prior score that Steffi went through, which was way easier. So the PREVENT implementation will require some more coding on the EPIC side, but if it's something that might be of interest for you as well, I think that we could work on this as a group and kind of promoting the need to have that available for our patients.
Definitely, I agree. It's very important to be able to include these risk calculators and help us to guide management and work together.
Yeah, exactly. Because again, you can pull up the website and put that in the tabs, but it's already everything in EPIC, so it might be nice just to have that as a dot phrase that gives you the actual numbers. And it's doable. It's just a little cumbersome, but it's doable.
Very good. Thank you, Dr. Avenatti.
Thank you.
Great job, Steffi. Proud of you. I think this was a great overview, and you tackled a very important sort of monumental topic. Just from a practical perspective, I mean, as you're heading out now back to the Valley where this is just an epidemic, as you're seeing patients in clinic and they're coming to you and they're probably already at CKM stage 3, how are you going to try to prioritize what to intervene with first, knowing that we sometimes have the challenges of pill burden, compliance with our patient? What would you try to prioritize?
And I think definitely, like we had a lot of slides mentioning, we see that progressive albuminuria is one of the main drivers of this progression. So definitely halting that. And with that comes with SGLT2 inhibitors. I think initiating that is very important, and educating the population. It's not just for diabetes as well. I think that's one of the things I'll be focusing on. But now that we're seeing more evidence with GLP-1 receptor agonists as well, and weight loss efforts, I think a more driving an effort for weight loss is going to be important in that population, especially that Valley population.
Yeah, no, that's great. I know you're going to do some great things when you get back there. So very proud of you. Great job.
Yeah.
Thank you, Dr. Edwards.
Very good. So I think that should be it for today's session. We have 2 more sessions in June for the academic year. Thanks everyone for attending, and enjoy the rest of your day and week.
Thank you.